Good afternoon. I'm Dr. Steve Ratcliffe. I'm one of the full-time faculty members at Spear Education here in Scottsdale, Arizona. Thanks for joining me for this webinar with Heraeus. Today we're going to spend a little bit of time talking about anterior guidance. This is kind of a passion for me. I love occlusion, although I didn't like it in dental school. I don't know how many of you had it as your favorite subject. I sort of came about it honestly. I had enough stuff break that I decided to learn about it. And then I've been teaching occlusion for many years, so it's fun. It's also fun for me to do this webinar. Heraeus has been a great sponsor for us at Spear Education. They've been great partners and support our in-house courses with materials and things that we use in our workshops. So we're grateful to them. I also was looking through a list of the participants here, and it's fun. I see a lot of familiar names, folks I've met over the years as I've taught, and even a former classmate from dental school in Cincinnati. Hi, Joyce. Hope you're online. Interesting thing about occlusion is, I think I had a pretty good education in dental school, but really what I got out of my occlusion courses is you just ground on the dots until everything seemed to fit. And then I got out into practice, and I'd see stuff like this, and it would scare me to death or it wouldn't scare me to death, which is even more frightening because I didn't know what I was looking at. And if I'm going to restore this, even if I know how to figure this case out, I need to make sure that it's going to last as long as possible. So what are the things that I need to know? I was doing a lecture one day, or putting together a lecture one day a few years back. And Frank actually happened to be lecturing at the time, and he came back and he looked at this slide that I had up on my screen, and he said, "Wow, Steve, nice veneers." And of course, my chest got all puffed up because Frank Spear had said nice veneers. It never really occurred to me that if they were really nice veneers, he wouldn't have recognized that's what they were. But he pointed right in here to this embrasure. And he said, that's exactly what we've been talking about. That's the embrasure form that's so important, not only in aesthetics, but in function. And I didn't want to tell him that this was the slide of that same veneer 3 days earlier. My patient had created that embrasure form for himself. I didn't know at that point what I didn't know. I didn't understand how anterior teeth worked. So part of, when we're talking about anterior guidance, and we're talking about how to protect our restorations and how to make them last, there are a couple of things that I want to do today. One is I want to talk about what we need to look for. I want to talk about 3 millimeters in morphology that are really important to a great functional result. And then finally, the very last thing I want to do is show you with just 2 brief examples how I use composite, both composite for provisionals as well as composite mock-ups, to test my occlusal theories and the great advantage they give us for long-term provisionalization and those kinds of tests. So one of the first things I want to think about is what is my, in part of my exam, where are the teeth, what's touching that maybe I don't want to touch, what's loose, and can the lower front teeth move within the arch form of the upper front teeth without bumping into anything? If I start with fremitus or mobility, that's the easiest thing to check. I can just put my index fingers on the front teeth and have my patient tap up and down, and if I feel those teeth move or bounce, that's fremitus. Those teeth are loose. They're actually moving in the socket to get out of the way of the lower front teeth. If I leave them that way, and I'm going to restore those teeth, I have a chance that my porcelain will break. If just the natural teeth, I have a chance for other breakdown that can occur down the line. If we look at this young lady who walked into my office a few years ago wanting veneers before her wedding, she didn't like the 2 porcelain crowns that were on her laterals. And she had broken her 2 front teeth in a horseback riding accident. And there was one further complication. She happens to be my daughter. So that'll make your tummy squeeze a little bit anyway. What do we need to know for Megan to get a good result? Now, if we look at, when we go back to the parameter about what's touching that shouldn't touch, one of the things to know about Megan is that we identified at a very early age that she was a heavy nighttime grinder, and so she's been in a nighttime bite splint since the age of 14. And fortunately, because we recognized that early, she hasn't created a lot of damage to her teeth, but she does have some significant wear facets. So what do we need to do with the front teeth to help protect the back teeth, to minimize muscle activity, because we can't stop her from grinding, but we can reduce the amount of friction or resistance that occurs so that when she does grind, things move as smoothly as possible and she gets worse as slowly as possible. Bob Barkley said that's really our goal for every patient, is to help them get worse as slowly as possible. So in Megan's case, this is the bite splint that she wore, and I've just sprayed this bite splint with contrast powder. It's something that your ceramist uses often to look at contours on porcelain. And if you look at what Megan has done in the 3 months between adjustments that she's been wearing this bite splint, you can see that this young lady spends a lot of time rubbing her teeth together at night. As a matter of fact, although her 2 front teeth were broken in this horseback riding accident, and everything that's incisal to that red line is composite, these incisal edges keep chipping. So I want to stay curious about why that is. What's happening when Megan moves her teeth around that may be contributing to that? I happen to be pretty confident in my bonding technique, so I can't blame my assistant for handing me the wrong stuff. I can't blame the composite for being weak. When I see this sort of wear that is isolated to the mesial incisal angles of central incisors, I need to be strongly suspicious that there's an occlusal problem, that there's some sort of habit that this young lady is engaging in that's causing the composite to continuously break. So we work through Megan's bite splint and adjust it on a regular basis, and that gives us clues as to what she is doing with her teeth and how she is moving. Now, normally, what I used to do is a patient would come in and I'd say, okay, let's make these aesthetic changes, and we do the wax up and we create the restorations. And I still do that once I understand what's going on with the jaw joints and the muscles. But there are some things that I think we need to be able to talk to our lab about and understand what our lab is giving us back, rather than just turning this over and say, do the wax up. So I need to understand how the front teeth work in function. I need to understand how they work in parafunction. And then I need to understand a concept that we call pitch and bevel, and how they contribute to smooth anterior guidance, because smooth really is the word. So let's look at a little movie clip of this anterior guidance. So Liz is going out into protrusive and into protrusive crossover. Now she's going to go out to the edge-to-edge position and try to slide side to side. And I want you to notice there, she can't stay on those incisal edges. She falls off. Now watch when she tries to move into left lateral. She can't do it. She's catching on back teeth. Now she's going to go back and she's going to try and move into right lateral. And the same thing happens. She's running into posterior teeth that are preventing smooth function. So if I'm going to build porcelain in a bite like that, there are probably some things I need to pay attention to. So let's think about 3 millimeters. 3 areas of anatomy that if you are aware of them and you can advise your lab, you'll get much more predictable results. The first is actually on the back teeth. And if you look at the marginal ridge in this woman who happens to be about 30 years old, and what I want you to notice is how wide they are. And I want you to notice how long they are. So one of the things that most of us are taught when we're making an occlusal adjustment is that we need to have cuspid guidance, and we need to have immediate cuspid disclusion. Now, the problem with immediate cuspid disclusion is if the front teeth are hitting as hard or harder than the back teeth, we may end up with fremitus, or the bite may feel locked into the patient. And so actually, one of the last things that we do is sit the patient up, and we adjust their front teeth so that we can slide a piece of articulating paper through their front teeth and make sure that there's no fremitus. Well, if we're going to have smooth function, we need to pay attention to what's called disclusion time. And disclusion time is nothing more than the amount of time the lower back teeth slide together until something causes those teeth to disclude, hopefully the canines, or if it's group function, the canines and the premolars. So I want to make sure that this marginal ridge right in here is flat enough and wide enough so that the lower opposing tooth can hit it and slide on a flat surface without moving up an incline. So if you look at the green mark, that's the excursion. The patient started to slide to the right. If you look at the red mark, that's the centric stop when the patient was tapping. So this green halo here is the amount of disclusion time before the patient picks up the canine. It's not very much, but it's a smooth, flat surface that the jaw can slide against until it begins to disclude. Sometimes, in order to get a smooth disclusion, we need to have group function. And you will not be damned to dental purgatory if you create group function. The important part is if you're going to share excursive movements with posterior teeth, that it needs to be smooth. The second millimeter that we want to look at is called the disclusion angle. And what I want you to look at is this canine. It had a veneer that was placed to both close a diastema and also to make the tooth longer. Now when the patient starts to slide to the right, notice what happens. The contact opens up. That's what we call functional mobility. Disclusion angle is nothing more than the steepness of the anterior guidance. It's the angle between the facial surface of the lower tooth and the palatal surface of the upper anterior tooth. So a steep disclusion angle would be on the left here, and a shallower one would be on the right. Now, that disclusion angle can be modified without affecting aesthetics, simply by flattening this line angle on the upper canine. You can create a flatter disclusion angle. So one of the things that Williamson showed in his muscle study in 1983 is that the flatter that angle is, the less muscle activity it requires for the jaw to move. Makes sense, doesn't it? So the other thing to think about, though, is force. If we're going to create longer teeth, we may be in danger of steepening that disclusion angle. And Weinberg, in a study on, which it was actually a study on implant abutments, talked about for every 10-degree change, there was a 35% change in the amount of force. So the steeper the angle, the more force it requires to move for the lower canine or lower anterior tooth to move against the upper anterior tooth. So really, the best analogy would be to think about climbing up a hill. So what's harder to do, climb up a steep hill or walk down a flat road? So when we're thinking about anterior guidance and creating smooth function, we want the road to be as flat as it possibly can be without creating an effect on the aesthetics. And you can do that by paying attention to those line angles on the palatal surface. Now, lengthening teeth inadvertently, if you look at this diagram and you think about lengthening the tooth, let me go back here. Look at the disclusion angle. Now look what happens when we just add length to the tooth. We've just steepened the disclusion angle significantly. So steepening that angle again can cause a violation of the envelope of function. This is what sometimes happens. You may have had patients who tell you that when they're chewing or speaking, sometimes their front teeth crash together. That's a violation of the envelope of function. It just means that the upper front teeth are either too long or the disclusion angle is so steep that the lower front teeth can't function within the steepness of those angles, and it needs to be shallowed out. We need to create more overjet. The third millimeter to think about is the incisal table. Classically we call it the incisal edge, but I want you to think about it as a table, much like we think about an occlusal table on a posterior tooth. And it has three distinctive parts. It has what we call the pitch, which is like the pitch of a roof. The pitch is the angle of that incisal table. And then there's the bevel, and the bevel has what we call a leading edge, which is on a lower anterior tooth, is the facial surface. And then there is a trailing edge, which is the lingual incisal edge on the lingual surface of the tooth. The leading edge is functional, the trailing edge is parafunctional. Now if you look at the blow-up of Lee's teeth here, you can see that this edge, this bevel, is smooth and very well refined. And it's not very big. It really is maybe 1/4 of a millimeter. And it's refined simply by taking a rubber wheel and moving around the tooth to polish it. The upper morphology is the same. There's a pitch and there's a bevel. Now on an upper tooth, the leading edge is on the palatal surface and the trailing edge is on the facial surface. So they look something like this. It is not realistic to expect your laboratory to be able to get this just right in their porcelain. You're always going to have to make some minor adjustments in the mouth to make sure that you have a well-refined pitch and that the bevel is polished. And the whole reason we refine these is for smooth function. So, and it's function in not only function but also parafunction. So the crossover position is one where the bevel really comes into play, and it is a parafunctional position. It's a movement past the canines and lateral, or a movement past the leading edge of the anterior teeth as the patient goes into protrusive. So here this patient has moved past the edges in protrusive, and then as she slides side to side, there's smooth function as there's incisal table to incisal table. Now if she goes back into the maximum intercuspal position and begins to move into right lateral, you can see that disclusion is beginning right here on the canine. And there's separation now between these front teeth, but not very much because we have a very shallow anterior guidance. And now the canines cross over. So this right lateral excursion, Lee has moved all the way out, so the canine has crossed over. And if you look at the centrals, notice that the incisal tables have landed against the incisal tables of the lower. And as she moves further, they're still sliding smoothly against one another. Now in a patient who demonstrates no signs of anterior wear and isn't bruxing or clenching, this isn't maybe not so important, and we probably can do our composites or porcelain restorations and not worry too much. But in a patient who is a bruxer, somebody who has a history of parafunctional habits, we really want to make sure that these edges and tables are refined. Now, protrusive is leading edge against leading edge. So leading edge of the lower against leading edge of the upper. Protrusive is a functional movement until those edges come together in an edge-to-edge or a table-to-table position. And if you think about the movie that we showed a moment ago, where Liz was having trouble falling off of her incisal edges, it's because they weren't refined. And the way we refine them is that the pitch of the upper front teeth should mirror the pitch of the lower front teeth. We don't do that for function, we do it for parafunction. If you go back to dental school and you remember the dreaded Posselt's diagram that we all had to memorize, all of the gray is parafunction. The green is function. That's the functional envelope. So we want to make sure that the lower anterior teeth can move smoothly within the functional envelope and also move past the functional envelope without anything catching or getting in the way of those movements. The idea is as little friction as possible. So on the lower anteriors, sometimes we need to move teeth orthodontically in order to line things up. Sometimes we need to just adjust them. And what I would like you to look at here is, in Mary Jane's case, notice the incisal embrasures here are non-existent. Because she was a chronic bruxer and grinder and she spent a lot of time rubbing her teeth together, we're going to make sure that those incisal embrasures are minimized so there is no place for her to catch or click against when she moves her jaw side to side. So this is the way that we do it. As the restorations are placed, whether it's our provisional restorations or a composite mock-up, we're going to adjust the edge-to-edge and the crossover excursions. So I'm going to have the patient move into protrusive and using sandpaper discs or porcelain wheels, whatever the appropriate abrasive is, I'm going to refine the pitch of the upper and lower teeth so that they're mirror images. Then I'm going to do the same thing on the canines. So there's actually an incisal table on canines, and I'm going to create a flat landing spot on those canines so that when the patient slides to the left, it's a smooth movement and nothing impedes that movement. I'm also going to make sure that there aren't any posterior interferences. So if you take a look at Lee's case here on her models, she's in an extreme left excursion. And this is a crossover interference. It's the upper premolar against the lower premolar. So this needs to be adjusted out of the way. Otherwise, it can become a habitual play spot. And I'm sure you've had conversations with patients before, and you've mentioned to them that you think they grind their teeth, and they say, no, they don't. You can either argue with them, or sometimes you can just say, well, one of the things that we know is that for teeth to have wear, they need to rub against something that's of equal or harder, rub against an equal or harder substance. So why don't you just, until I see you the next time, every once in a while put your brain on the top of your teeth and see what you're doing. This is, what's interesting is for those of us who are dentists to do this. And one of the things I would suggest to you if you wonder if you have any daytime habits is the next time you sit down at the chair with a patient, as soon as you put your mask on, pick up your high-speed handpiece and put your foot on the rheostat to start that handpiece, stop for a minute and see what you're doing with your teeth. That was the case here with Lee, who happens to be a dentist. She had no idea that she would rest on this spot and rock back and forth until one day she was at the chair after we'd done an adjustment and remove this interference, and she was looking for it. It actually took her 2 weeks before she stopped looking for this play spot. So try it yourself. See what you discover. You may find that you've got your own play spot. Now I want to make sure, as I said, that both centrals contact end-to-end and protrusive through there. And as we're moving in extreme lateral and protrusive, sometimes there can be little catches. So notice how much space there is between the incisors as this patient goes into right lateral. And this patient rides up on the canine. So you can see there that there's a wear facet on the canines. The patient has spent some time going out there. And it's rough, and the patient actually has a little catch there. So our choices in a case like this is we can either make the front teeth longer so that the front teeth, the incisal tables contact sooner at the same time as almost the same time as the canine is end to end. We can shorten the canines. So in this particular case, we decided to just shorten the canine, shorten the distal arm of the canine, and polish it up a little bit. So you can see the difference from the left screen to the right screen, like so. And now see how quickly those centrals touch? That's the crossover position, moving into the crossover position. So the incisal tables have been refined so that the patient can move smoothly. Now, if we don't do that, sometimes we end up with a situation like this, where this lower veneer fractured. This is a crossover interference. This canine was much longer, the lower canine was much longer. The patient would move into left lateral and then would pull back. So the patient was actually moving this direction and would brace against the lower canine and would hold that position and just squeeze against it. And something had to give. Either teeth were going to get loose or something was going to break. And in this case, the veneer broke. So to kind of summarize why we do all of this, really, flat surfaces distribute stress, and they give the muscles a place to rest. So here's a little game you can play. I want you to imagine that you just picked up 2 marbles. And I want you to balance those marbles between your thumb and your index finger. And I want you to think about what you're doing as you try and balance those 2 marbles. When you squeeze them together, what happens? It's really hard to hold them, isn't it? They're sliding all over the place. You can't keep them balanced. They probably squirt out of your fingers. Now, if we took those same 2 marbles and we went back into the lab and turned a grinder on, a disc, and we held the marbles up to the grinder just for a moment and did a little zip so that now there's a little flat spot on each marble, and we put flat spot against flat spot. Now try and balance those 2 marbles with the flat spots against one another. You can do it. You can hold the marbles. You can turn your hands any direction that you want to. You don't have to, your tendency is not to squeeze so hard because you don't need to. That's why we adjust incisal tables and why we make sure that the interincisal angle and the disclusion time are all smooth. We want to eliminate stress. We want to eliminate the amount of resistance and friction that occurs when people rub their teeth together. We know that most of the time, just organizing the bite is not going to stop people from grinding or from whatever habits that they have. So our job is to minimize the risk when we place a restoration there. We know that the studies by Guy Levine, who probably knows more about sleep-disordered events in dentistry than anybody alive, tells us that 8 to 10% of the population are chronic nighttime bruxers. They have a CNS disturbance, and we know what happens to those people. We know that they grind viciously. What he also tells us, though, is that 20% of the population have daytime habits, where they're clenching, grinding, squeezing, bruxing. And it is very difficult to control those. So if you think in your patients with habits that giving them a night guard is going to protect your porcelain, that may be true at night, but it's not going to do much for you during the day, because most people aren't going to wear an appliance during the day unless they have jaw pain. So that's the whole rationale for paying attention to the way the teeth rub together. So this is Megan's final result. We want to test this in composite. And so I go from the wax up. This happens to be a set of composite veneers that I did. This happens to be Venus before the new nanotechnology. So these are a number of years old. I wasn't using a bisacryl at the time. I was actually using composite, and these have been in the mouth about 8 months. So it's a long-term test in this chronic bruxer of what she's doing with her teeth. Now, the other thing that we want to pay attention to besides the incisal tables are the embrasures, because they're there for a reason. You saw in that earlier slide that my patient created his own embrasures. So one of the things that we know about embrasures is that when you move from centrals back to the canines, the embrasures become progressively deeper and wider. And that not only is that aesthetic, but it's also functional. So if you look at Lee's case and notice the deepest embrasure is between the canine and the lateral, the purpose there is so that the lower canine can pass through. So pay attention to embrasures as part of, not only as part of your aesthetic workup, but also as part of the functional workup. Pathway violations we talked about. And when you're looking at your composite mock-ups or your provisionals, here's some things to pay attention to. Is there abnormal wear on those provisionals? Are they loose? Are they moving? Is their fremitus back? Do your provisionals pop off? Does the patient complain of speech difficulties? Frequently, if those things happen, you want to look at the way you have lengthened anterior teeth, and you also want to look at the disclusion angle. You may have encroached on the pathway that the lower teeth need to have to be able to function normally. Now, I want to spend a few minutes talking about instrumentation, because this is critical when our lab is going to do a wax up and when we're actually going to construct restorations. We want to be able to duplicate jaw movements as closely as possible. Now, if you were like me, you sold your articulator as soon as you finished dental school because it didn't seem to make a whole lot of sense to have it. But truthfully, being able to use a semi-adjustable instrument will make your life easier and actually make your restorations more predictable. So the face bow transfer is just a simple way to orient the maxillary cast to the aesthetic and occlusal planes relative to the skull and to the condyles. So it gives us 3 points of reference so that we can always orient the upper cast appropriately. Here's another reason why we want to use a semi-adjustable instrument rather than the hinge type articulator. Now, I'm not saying you should never use a hinge, because there are times when I use a triple tray. There are times when I use a hinge like this. But I need to understand the difference between the hinge and a semi-adjustable articulator and the effect it can have on anterior and posterior tooth relationships. So we know that the condyle has a relationship to the occlusal plane. And we also know that as the jaw opens and closes, that it opens on an arc. And we know that that arc is largely dependent on the distance of the condyle to the teeth. So if we use a little hinge type articulator, it changes the position of that condyle relative to the teeth. And so when you open that hinge, it gives you a different arc of opening and closure. So you may actually build in occlusal interferences and end up having to adjust more porcelain in the mouth than is actually necessary. Now, the other thing that happens when we think about excursive movements, we know that the distance between the condyles in the average human is, say, 110 millimeters. And as the working side rotates, it creates an arc that the lower teeth pass through. And we want to make sure that those lower back teeth don't run into the upper back teeth. Well, once again, if we're using that little hinge articulator, it changes the entire arc of rotation. So again, we may be building in interferences that don't need to be there, and we end up grinding on our nice new restorations when we really didn't have to. And then the final thing is, if I'm going to use a semi-adjustable instrument, there is a very fast record I can make called a protrusive record that allows me to set the condylar inclination on the articulator. All I do is have the patient bite forward onto a piece of wax. And then I set the instrument, and this gives me a representation of the angle of the eminence and the pathway that the condyle travels. In a semi-adjustable instrument, is it an exact replication of the condylar path? No, but it is close enough that I can eliminate some posterior interferences that I might build into the case, and it also makes my anterior guidance more reliable. And that's just the way it's set. So this is Megan's case. Again, these are a couple of, the provisionals are all done in composite. I use a lot of bisacryl now, but at the time I was using composite. And so these are Megan's excursions. She's edge to edge here. She's moving into right lateral, and see there's just barely any space between her centrals, and then she moves into crossover, and she lands on the central incisors. And then we finish the restorations, and if you look at the excursions here, they are an exact duplicate of what the provisionals were. So those composite provisionals allowed me to test my theory. I was able to work through all the excursions, make any adjustments I needed to make on the provisionals, make an impression of those provisionals, and send it to the lab. And so she's got a great predictable result. This is about 4 years out now. So it looks exactly the way it did when we delivered it. This is where I want to spend some time with you, talking about how you can use composite and some quick things that you can do with composite to make your life a whole lot easier. So if you've got a mock-up or a theory that you want to test, sometimes I'll do a quick little wax-up in the lab, and all I've done is just add some length to some teeth. This is Lee's case again. And so I just quickly added some beige wax, and then I can go over that wax with a material that Horaeus makes called Memicil. And Memicil is a clear vinyl material that you can cure through. Now, what we've done here is just put little vent holes in the Memicil, you can just go in with a round burr, carbide burr, and just pop little holes in there. This happens to be a different case. This isn't Lee's case, but I'm going to lubricate the Memicil, and then I'm just going to layer in warm composite. I like to use a carpial warmer because it's just easier to get the composite to flow in the Memicil. And I've etched the incisal edges of these teeth that we want to lengthen. And then I just pop that Memicil in and cure through it, and I get something like this. So this is a mock-up that I can work through all the excursions with Lee. She gets to look at it. If she wanted to go home and wear it home, she could. If if we decide that the function is what we want and the aesthetic length is what she wants, then I just have to make an impression, and then my lab can do a more formal wax up for me. So Memisil and Composite, and it's a great combination. It's quick to use. It's really a nice way if you want to do something a more permanent restoration or a longer term composite. You can do that and then just take diamond strips and separate the teeth and clean them up, and you can even do longer term composites that way. So there we get to check all the excursions and everything's good. In this particular case, we just made an impression and then knocked it back off. Now, here's another way to really use composite long term. This happens to be a wax up for a gentleman who had severe erosion and attrition. And we wanted to test our occlusal theory. He also was in a financial position where he couldn't do all of the restorations at once, and we wanted to phase the case over 18 to 24 months. So we decided to build up the entire case in composite. So we made vacuforms of the wax up, and then we take this to the mouth, and what I did was cut out all the old restorations. I removed all the old composite veneers on the front of his mouth, and you can see on the left screen that there was some darkly stained dentin and also deeper spots. And so we bonded those. We used gluma to make sure that there was no sensitivity afterwards, and I just did individual little composites to build the deepest parts up, so I didn't have to worry about the next step, which is using those vacuform matrices and fill them with composite. So if I just filled the vacuform with composite and expected it to go down into these deepest areas, it wouldn't have been. So I actually did these with matrices and a rubber dam to make sure that they were well sealed. Now I'm using Gluma Power Gel, and one of the things I wanted to mention about this is make sure you really follow the directions with Power Gel. It's wonderful. It stays where you put it. You don't have to worry about the tissue sensitivity from it running all over the place. But if you're in an aesthetic critical area, you also want to make sure that you wash it off thoroughly and within 30 seconds, because you'll actually get some dentin discoloration from the Power Gel. If you follow the directions and use it as directed, that's not an issue. And like I say, I really like it because it doesn't flow all over the place. It's easier to control. So here are the anterior teeth with all of the old composite veneers removed, and there's the wax up. Now we're going to do a couple of things here. We're going to use the composite not only as a long-term provisional, but we're also going to use the composite as a surgical guide for the periodontist. If you look at the wax up on the right screen, you'll notice that the gingival margins were waxed to the preferred contours, much different than what you see on the left screen. He's got some altered active eruption on that left canine. The gingival level on the right canine, the gingival level on the right central is much shorter than where we want to end up. So I'm going to use that matrix, this matrix. I'm going to trim it right to the gingival levels, and then I'm going to take either my laser or an electrosurge, and I'm going to carve the tissue to follow the gingival levels on these three teeth. And then I'm going to bond the composite in. So I used the matrix and filled it with composite. You can see where I carved the tissue. You can see a little bit of charring there. So now, when this heals, the periodontist has a surgical guide as to where I want the gingival margins to be in the final restorations. So when the periodontist goes in and does the crown lengthening procedure, he knows exactly where the cervical margin of the teeth will be, and he knows to scallop the bone about 2 millimeters above that surgical margin, because we know that the biologic width will reestablish, and if the bone is 2 millimeters below the surgical margin, if everything is average, we should end up with about a 1 millimeter sulcus. So we did the same thing, upper arch and lower arch. This procedure took about 6 hours to do the entire thing. I didn't separate the contacts because we thought, or in the anterior, I didn't separate the contacts because we thought this was going to be a relatively short term. We hadn't planned on this being a permanent restoration. Had I known it was going to go as long as it has gone, we would have gone in with with diamond finishing strips, and we would have separated things. So this is the way he ended up. Lateral shots. You can see that we've worked out all of the anterior guidance just the way that I showed you. This is about 3 weeks after. Now, the tissue here looks great 3 weeks later, but the fact of the matter is I violated the biologic width on these 3 teeth when I cut that tissue back. And as it starts to reestablish, this tissue will get angry and red. So the plan was that the first thing he was going to do was go see the periodontist and have the crown lengthening done. That was going to be phase 1. I saw this patient when I was living in Miami, when I was at the Pankey Institute, and just about the time we had planned to move forward, the economy tanked. His business was hurricane shutters, and his business just went south, and he disappeared. I couldn't get him to come back in. The dentist that he is now seeing, who just saw him not too long ago and happens to be the dentist who initially referred him to me, sent me these photographs. So this is 3.5 years later. Aesthetically, he's delighted. It's probably too good because he's saying, why would I want to do anything different? This is working, and my business isn't any better. But this is what I want you to look at. These 3 teeth, he hasn't done a great job of taking care of his mouth. But look how angry the tissue is around 6, 7, and 8. That's the violation of biologic width that I was talking about. However, nothing is chipped on the composite. This is all venous diamond. When I layered it in, I layered a little bit of incisal into the anterior teeth, but mostly it's just a solid body shade. The idea was to create cut-through provisionals, so that not only would these provisionals act as a surgical guide, but they would also act as a preparation guide so that I didn't have to over-prepare teeth. So you can actually begin to cut these provisionals just as they were a full contour tooth, and you'll cut less tooth that way. So anyway, in summary, pay attention to the incisal tables. You can use composite as really great ways to test your theories and make sure that you've got the anterior guidance correct. You can use it as a long-term provisional. It's a solid material that will add to your toolbox. So I'll take questions now for about 10 minutes. Let's see, I've got a question here. What are you looking for when I'm adjusting the bite splint? And I think the quick answer to that is I want to end up with very flat receiving areas on the back of the bite splint. And then I want to adjust the front of the bite splint just like I would anterior teeth so that the patient can go out into protrusive smoothly, can move into right and left lateral smoothly, and can move into right and left crossover smoothly without any of the upper front teeth catching on the lower anterior part of the lower bite splint. Other questions? Question, what do you look for in a bruxism appliance in terms of thickness and occlusion? I like to have a couple of millimeters on the second molars because I'm going to make adjustments. So that's kind of my standard thickness. Question is, what would I use to separate the anterior contacts? I use Brasseler's diamond strips and work through the contacts. There's also a interproximal saw. Axis makes interproximal saws, and Axis makes interproximal saw. Oh, and Denmat I think has an interproximal saw, but I'm not sure they still make it. Question is, what do you do in a class 2 situation where there's no contact in the front and only posterior molars are touching? I think the short answer to that is, if I can reshape teeth so I can get more posterior teeth touching, I will do that. I have to evaluate whether it's a surgical case. I have to evaluate whether it's really a problem for the patient. If it's not a problem, if the patient doesn't have wear or broken down teeth and can eat anything they want, there isn't an aesthetic issue, I don't do anything. But I like to get if I can, I like to get the anterior guidance as far forward as fast as I can. So if only molars are touching, that's where the anterior guidance is. So I'd like it, if I can get it up to premolars at least, I like to do that. One of the questions was, is the correct spelling Nemosil? No, it's Memosil, M-E-M-O-S-I-L. Let's see. The question is, do you even anterior guidance or the incisal table prior to posterior equilibration or in reverse order? I love that question. It's a question that people have wrestled with for a long time. Classic equilibration was you would guide the patient into a seated condylar position, or what we call centric relation, and then you would adjust all of the back teeth until the front teeth came back into contact. I prefer to adjust the anterior teeth first, because if I'm adjusting all of the back teeth until the front teeth touch, and then I go ahead and adjust the front teeth again as I move through all the excursions, I may end up taking too much tooth structure off the front teeth. So I have the patient move into the end-to-end position, into right and left lateral, and get that as smooth as possible. And that means sometimes I will have to remove tooth structure on posterior teeth. So the question is, posterior interference, put it in perspective. My feeling is flatter the anterior guidance, the better. I agree. The flatter, the better. I want the anterior guidance to be as flat as it can possibly be and still disclude the posterior teeth. Do I believe in composite as a definitive treatment material? Sure. I love composite. I think with the layering techniques that we have now, with the nanotechnology, I love Venus Diamond. I love the way it polishes. I love the way it handles in my hands. It's my go-to composite. I think that there are things that we can do now with composite that we would have done porcelain veneers on 5 years ago, and I would choose composite now because it's less invasive, it's beautiful, and it's less expensive for the patient. And I think many of our patients today are looking for aesthetic solutions that are less expensive. So if I can do something, L.D. Pankey said 50 years ago, the best dentistry is the least dentistry. So if I can do something that requires removal of less tooth structure that makes sense, I'll do it. Where else am I lecturing? I'm easy to listen to. Well, thank you, Bob. I'm going to be at the ADA. I'm all over the place. You can email me at this email address, and I'm happy to let you know where I'm going to be. Oh, what do you use for polishing composite? Thank you for asking. I use a series of sandpaper discs that are progressively finer grit, and I also use I like the different composite polishing points that are available. I like the pogo points. And then I like to finish it with a high luster diamond polishing paste followed by a polishing cream. Let's see, did I get them all? Do I use retraction cord? Yes, sometimes I do use retraction cord, especially if I've got a margin like on Jose's case where I'm not going to be using the composite as a surgical guide. I think it's a great technique to make sure that I've got a dry field. What's the minimum freeway space I set for opening a closed bite? I don't use a minimum. The thing about freeway space is the literature tells us that in most cases, unless you really overcorrect, freeway space returns in 2 to 4 months. So if I open the vertical 2 or 3 or 4 millimeters and the patient feels like the muscles are a little stretched or they feel like they've got a little bit of speech difficulty, I tell them to give it a little while and see what happens before we make any changes, and freeway space will come back. Relate anterior guidance and the angle of the eminence. Angle of the eminence doesn't necessarily have a direct effect on anterior guidance, but angle of the eminence does have an effect on how quickly the posterior teeth disclude. So if I have a really steep angle of the eminence, as soon as the condyle starts to translate, the back teeth separate very quickly. And sometimes it's easier to build a really flat anterior guidance in when the angle of the eminence is steep. If the angle of the eminence is really shallow, the movement is very horizontal, and it's harder to build a flat guidance that looks aesthetic, I guess is the point I was trying to make. What articulator do I use? I use 2 articulators. I use the SAM3 and I use the Danar 330. I like them both. With canine guidance, do I always remove posterior contacts in protrusive movements? As a rule, yes, but sometimes, for instance, in an end-to-end occlusion, sometimes there will be some protrusive contact on premolars. But most of the time, yes, I would remove those posterior contacts. How do you maintain vertical through polishing? I don't. When I'm polishing, I'm not taking that much off, so it usually isn't an issue. Translucent effect. I use translucent composite, the enamel shades. So I'll typically start with enamel and then layer, start with a dentin shade or a more opaque shade and then layer the enamel over it. And Heraeus just has some new opaque shades that are kind of cool too. So one more question. What material do I use for occlusal appliances? Truthfully, I use jet acrylic. I still make my own. Other people do lab processed appliances, and those are usually made with a clear denture acrylic. So that's what I use. All right. So, folks, thank you very much for being with me. I appreciate it. Email me if you have questions. I usually I do my best to answer them within a couple of days, although I am leaving town for 10 days on Friday and I won't have email or any contact with the rest of the world. So I'm going on vacation. I'm going to go fishing in Alaska. So have a great afternoon or evening wherever you are. Thanks for being with us.